Hello everyone. I would like to introduce you my PhD topic about treatment possibilities in oro-maxillo-facial rehabilitation. My name is János König from the Department of Prosthodontics, and I would like to work in the field of maxillofacial prosthodontic, which is slowly becoming evidence-based. So to replace the current improvisatory nature of this field, we have to first establish proper scientific output. Here are my 3 projects to achieve this mission. The first project is about optical scanning in facial prosthetics, because annually and globally more than 600,000 people develop head and neck cancer, and some of them result in a defect which is unrepairable surgically. Only prosthetic treatment is available, but this prosthetic treatment is inaccessible for many due to the high costs and technicalities. But digital technologies may be the reason behind making these treatments more accessible for many due to a trickle-down effect. So we are in a need of a reliable impression taking of the patient's faces to fabricate a facial prosthesis. Our aim is to compare industrial scanners in different regions and across different technologies by comparing their trueness to each other, meaning that the linear measurements on the scanned model would be compared with the direct clinical measurements taken on the patient's face. Our hypothesis was that the laser scanning is the most inaccurate, especially in the orolabial region, because this region is more susceptible for involuntary movements during the capturing. How is it significant in the clinical field? Because if we take an impression which is distorted at the very beginning, then the end result, the final result, the final facial prosthesis would be also not accurate. Based on this quick calculation, a wider gap than 0.3 millimeters would be visible during human interaction, so this can be a threshold for our calculations. We conducted the systematic search in last October, and at the end we got 10 eligible articles in our meta-analysis. All the baseline data was collected in a huge table, and due to time constraints I'm only showing you the nasal region. So we've picked 3 interlandmark distances representing the width of the nose, the height of the nose, and the depth or the length of the nose. And what we are seeing here with a very low amount of heterogeneity, the overall effect size is much more, so the confidence interval is much more narrower than the individual articles, but this is not narrow enough for this clinical field, because the confidence interval shows that the differences are scattered wider than our threshold. And we've conducted another analysis by transforming the different interlandmark distances with different magnitudes by comparing them in a standardized mean differences analysis. And what we are seeing here is that along any axis there is no systematic difference or systematic error in the measurements. We've also collected the difficulties mentioned in the articles, and most articles mentioned the artifacts in the images due to the longer capture time and involuntary movements or blinking. The strength of this review is that no regional analysis was conducted before in this field, and the same methodology was used throughout all the included articles. However, there are limitations because not all regions, especially in the auricular region, was not involved in our article, and the involved population are mostly consisted of healthy individuals and not people with facial defects. And of course, the direct clinical measurements has their own errors or flaws, and they cannot be treated as absolutely true values. The conclusion is that the dimensions of the scanned models are not significantly different compared to the directly measured true values, but this is not in the clinically acceptable range just yet, and the clinical usability differs substantially from device to device. So our implication for research, for practice, is that scanning is preferable to traditional impressions in facial prosthetics, and for research, we have to conduct actual research with people with facial deficits in order to make sure that these devices are compatible with this field, and we should explore the learning curve of scanner usage. Unfortunately, this paper was submitted in July to oral oncology, but rejected almost immediately. And last week, we've submitted it to Journal of Prosthodontic Research. My second project is about treating maxillary defects. And these defects are coming from cancer treatment or surgical cancer treatment, and these patients are in need of some kind of rehabilitation, because imagine yourself with this kind of defect in your mouth. The main method of rehabilitation is surgical or prosthetic, but the choice between these two methods are controversial because it depends on the operators. Our aim is to compare these two methods as for the therapeutic effect goes by comparing the quality of life scores of these patients on different domains. And our null hypothesis is that there will be no difference in quality of life between these interventions. And if this is the case, that the prosthetic treatment is non-inferior to surgical treatment, this modality has lower costs, less complications, and provide an easier oncological surveillance. We've conducted a systematic search in May, and at the end, we got 16 eligible articles in our analysis. Due to there's so many parameters to include, so therefore I asked questions for the statistical group, but only the simpler questions were answered. So first one is about speech. Is speech more intelligible if the defect is surgically closed? And what we are seeing is with a very low heterogeneity is that there's no tendency or difference between these two treatment modalities. Is swallowing less effective if the defect is surgically closed? The heterogeneity is really high, and the overall confidence interval of our effect size is really wide, therefore not suggesting that either of these modalities were better than the another. Does the patient have less pain if the defect is obturated prosthetically? The same applies to this one as well, because of the high heterogeneity and the wide confidence interval. The other results are currently at work at the statistical group, and we are planning to do a meta-regression. The risk of bias was analyzed with the Romin's eye and the ROP2 tool, and by the end of September, I would like to submit this manuscript. My third project is about color matching in facial prosthodontics or facial prosthetics, because this provides a great challenge to match the skin color to the existing skin. Many attempts were made, but this is mostly done by trial and error. And even though colorimeters are capable of measuring color and light, but the dynamic color of the patient's skin represents an additional problem in this field. And what we don't have in facial prosthodontics is a proper quality control standard. So we cannot tell that when a prosthetic device is sufficient or not. So our PICO is currently under development, but the question is that what is the color difference threshold for perception, that what kind of color difference is perceivable, and what is acceptable in facial prosthetics. And our hypothesis is that the color meters will be accurate enough to detect perceivable color differences. And with this kind of information, we have a known color difference threshold, which could be an aspect of quality control in facial prosthetics. Currently, we are working on the Prospero submission, and I would like to thank you for your kind attention with a quote by a race car driver: "If everything seems under control, you are not going fast enough." Thank you.
Thank you for your presentation. I would like to ask about your third project, which is under development. Is this clinically relevant to match color with the patient's skin? Of course, it wouldn't be plain white, but doesn't it overcome by makeup in the daily practice by the patient?
Unfortunately, thank you for your question. Unfortunately, the silicones cannot be colored after it has been processed. So during the processing of this final silicone bit, so the color should be known by the time of this process.
Thank you for the nice presentation. I have a really silly question, but when do you recommend measuring the color of the skin in the summer or in the winter?
Well, these patients, well, in Western countries where this field is more financially stable, patients tend to have a winter prosthesis and a summer prosthesis. So therefore the question is not applicable.
I wonder if you are doing a prosthetic device, and you said 0.3 millimeter is the resolvable by the eye. Can you adjust it on the face of the patient after the device is done, or can you overcome of this little gap?
Well, this is what I meant by improvising. So therefore we have a structure where how to fabricate a facial prosthesis, but these tend to have mistakes, and improvising is how we solve these mistakes, unfortunately. So this is what we are currently doing.
That's the art. That's the art in it, right?
Sorry?
That's the art.
That's the art.
Nice,
that's the art.
Nicely. But you have instruments and materials for that.
We should have taken another impression with the faulty device on the face, but this is not considered to be accurate.
Mm-hmm. Any other question? Yeah, please.
A short question. How costly is this kind of, if I can say, small prosthetic for a face?
Well, it is around 800 euros nowadays, but it's getting more expensive and expensive.
Thank you.
Time.